Interventions for the management and prevention of fentanyl overdose. Similar treatments are prescribed for opioid use disorder and opioid overdose, including the Food and Drug Administration (in parentheses, FDA) approved medication methadone, buprenorphine, extended-release naltrexone, and naloxone. Lofexidine, a central 2A adrenergic receptor agonist, was the first non-opioid medication that was approved by the United States FDA for the treatment of opioid withdrawal. Lofexidine has fewer prescriptive barriers and comparable efficacy and safety relative to other opioid receptors agonists, but it's generally more expensive. Sparse data are available on the effectiveness of interventions to prevent overdose that are caused by illicitly manufactured fentanyl. Compared with other opioid-related overdoses, illicit fentanyl-related overdose appear to be accompanied by distinct symptoms, such as body and chest rigidity, dyskinesia, and slow or irregular heart rate, which can affect overdose management, such as oxygen provisions and appropriate doses of naloxone. To avoid or reduce the adverse effects of fentanyl, the FDA proposed to control the duration of use and doses of fentanyl. One study showed that the majority of patients who were presumed to experience a fentanyl overdose could be discharged after brief emergency room observation. Thus, unlike requiring additional naloxone dosing in the emergency room, there are limited data on the efficacy of methadone or buprenorphine for the treatment of illicit fentanyl use. A retrospective study in Rhode Island showed that 6 months of methadone maintenance protect against death and promote abstinence in fentanyl-exposed patients. With replace rates were still high. Buprenorphine is an opioid receptor partial agonist and key opioid receptor antagonist that is commonly used to treat opioid use disorder. It also exerts antidepressant and anxiolytic activity and is a promising treatment for neonatal opioid withdrawal syndrome. A retrospective cohort study showed that 6 months treatment retention rates and opioid abstinence rates were not different between individuals who were positive for fentanyl or heroin at Vaseline before initiating buprenorphine treatment, indicating that buprenorphine may still be beneficial for treatment fentanyl exposures. Repeated treatment with buprenorphine produces a great magnitude of antinociceptive tolerance that higher efficacy agonist in parentheses, morphine and etonisane in rates. Studies in pigeons and rhesus monkeys show that the amount of tolerance that develops to the reinforcing potency of opioids depends on their efficacy, and the higher efficacy opioid receptor agonist, so fentanyl, was more difficult to antagonize than the low efficacy opioid receptor agonist morphine. This data indicate that buprenorphine may have lower efficacy for the treatment of fentanyl overdose compared with heroin overdose, although human trials have been performed to date. Naloxone is an opioid receptor antagonist that is used to treat fentanyl-related overdose, regardless of the suspect route of administration. However, its efficacy is inconsistent and safe dosing needs to be considered from the perspective of participating opioid withdrawal. Recent studies also showed that the extent realized in naltrexone was equally safe and effective as a buprenorphine naloxone combination at promoting abstinence and treatment retention once treatment was indicated. Whoever participants successfully initiated naltrexone treatment. Large or repeated doses of naloxone are speculated to be required for the treatment of fentanyl overdose because of its higher affinity for opioid receptors. However, a study of a community naloxone distribution program in Allegheny County showed that the average doses of naloxone that were administered to reverse overdose did not change between 2013 and 2016, although the incidence of overdose that were related to fentanyl and its analogs increased during the same time. A retrospective study of the fentanyl epidemic in Chicago showed that doses of naloxone up to 212 milligrams may effectively to treat fentanyl overdoses. Naloxone was shown to reverse transdermal fentanyl overdose-induced sedation, the reduction of body temperature, and the reduction of heart rate in dogs. A systematic review found a low incidence of mortality or serious adverse events that were caused by pre-hospital naloxone administration in opioid overdose patients, although the source of overdose was mostly heroin and not fentanyl. Additionally, seeking emergency medical help was possibly associated with overdose victims who received higher doses of naloxone and rescue breathing in British Columbia, Canada. a survey a survey of 316 street repeat people who use opioids in Baltimore showed that the majority of them perceived the high risk of fentanyl, adulterate heroin, and overdose, but most of them did not often carry naloxone with them. The early adoption and distribution of take-home naloxone have been reported to effectively prevent opioid overdose deaths. Therefore, harm reduction strategies such as safe injection sites, the expansion of available opioid agonist treatment, and overdose prevention training. In parentheses, carry naloxone and not use drugs alone. Higher doses or multiple administration of naloxone. are needed to control the adverse effects of fentanyl and reduce overdoses. Previous studies have reported a vaccine consisting of fentanyl hapten conjugated to tetanus toxin or keyhole limpet amoxicillin carrier protein and immunization with these vaccines reduce fentanyl biodistribution to the brain and blunted its anticoncept effects and respiratory depression in rodents. Moreover, the conjugate vaccine stimulated the endogenous generation of antibodies with high affinity for a variety of fentanyl analogs and was shown to blunt fentanyl reinforcement. A recent studies screened purified monoclonal antibodies (MABs) from vaccinate mice and found that the 684 MAB prevent the acute lethality of fentanyl and reverse both fentanyl and carfentanil-induced anti-nociception and effects as naloxone. This induced anti-nociception as effective as naloxone 143. This finding suggests that immunopharmacotherapies, including active vaccine or its combination with past MBA, may be potential and promising treatment strategies to address the current opioids crisis. Accumulating evidence also implicates the dysbiosis of gut microbiome in the pathophysiology of drugs addiction. However, data regarding fentanyl use is rare. Manipulating the composition of the gut microbiome or its products may guide neoadjuvant therapies for opioid addiction in the future. In conclusion, the crisis of opioid-related overdoses. In conclusion, the crisis of opioid-related overdoses, especially fentanyl and its analogs, is a major threat to both individual and public health. Respiratory depression, cardiovascular effects, and neuropsychiatric symptoms are associated with fentanyl overdose and lethality. Naloxone is the standard rescue drug for fentanyl overdose, but its efficacy is inconsistent. Further clinical research is needed to optimize individualized medication-assisted treatments in patients who overdose of fentanyl and its analogs.